Welcome to the Dr. Izzy's Medical Podcast channel.
Thrombocytopenia. Thrombocytopenia is a condition characterized by abnormally low levels of platelets, also known as thrombocytes, in the blood. It is the most common coagulation disorder among intensive care patients and is seen in 20% of medical patients and a third of surgical patients. A normal human platelet count ranges from 150,000 to 450,000 platelets per microliter of blood. Values outside this range do not necessarily indicate disease. One common definition of thrombocytopenia requiring emergency treatment is a platelet count below 50,000 per microliter. Thrombocytopenia can be contrasted with the conditions associated with an abnormally high level of platelets in the blood, thrombocythemia, and thrombocytosis. Signs and symptoms. Thrombocytopenia usually has no symptoms and is picked up on a routine complete blood count. Some individuals with thrombocytopenia may experience external bleeding such as nosebleeds, or bleeding gums. Some women may have heavier or longer periods or breakthrough bleeding. Bruising, particularly purpura in the forearms and petechiae in the feet, legs, and mucous membranes, may be caused by spontaneous bleeding under the skin. Eliciting a full medical history is vital to ensure the low platelet count is not secondary to another disorder. Ensuring that the other blood cell types, such as red blood cells and white blood cells, are not also suppressed, is also important. Painless, round, and pinpoint petechiae usually appear and fade, and sometimes group to form ecchymosis. Larger than petechiae, ecchymosis are purple, blue, or yellow-green areas of skin that vary in size and shape. They can occur anywhere on the body. A person with this disease may also complain of malaise, fatigue, and general weakness. Acquired thrombocytopenia may be associated with the use of certain drugs. Inspection typically reveals evidence of bleeding, along with slow, continuous bleeding from any injuries or wounds. Adults may have large, blood-filled bullae in the mouth. If the person's platelet count is between 30,000 and 50,000 cubic millimeter, bruising with minor trauma may be expected. If it is between 15,000 and 30,000 cubic millimeter, spontaneous bruising will be seen. Diagnosis. Laboratory tests for thrombocytopenia might include full blood count, liver enzymes, kidney function, vitamin B12 levels, folic acid levels, erythrocyte sedimentation rate, and peripheral blood smear. If the cause for the low platelet count remains unclear, a bone marrow biopsy is usually recommended to differentiate cases of decreased platelet production from cases of peripheral platelet destruction. Thrombocytopenia in hospitalized alcoholics may be caused by spleen enlargement, folate deficiency, and most frequently, the direct toxic effect of alcohol on production, survival time, and function of platelets. Platelet count begins to rise after 2 to 5 days abstinence from alcohol. The condition is generally benign, and clinically significant hemorrhage is rare. In severe thrombocytopenia, a bone marrow study can determine the number, size, and maturity of the megakaryocytes. This information may identify ineffective platelet production as the cause of thrombocytopenia and rule out a malignant disease process at the same time. Treatment of thrombocytopenia. Treatment is guided by the severity and specific cause of the disease. Treatment focuses on eliminating the underlying problem, whether that means discontinuing drugs suspected to cause it or treating underlying sepsis. Diagnosis and treatment of serious thrombocytopenia is usually directed by a hematologist. Corticosteroids may be used to increase platelet production. Lithium carbonate or folate may also be used to stimulate platelet production in the bone marrow. Platelet transfusions. Platelet transfusions may be suggested for people who have a low platelet count due to thrombocytopenia. Thrombotic thrombocytopenic purpura. Treatment of thrombotic thrombocytopenic purpura, TTP, is a medical emergency, since the associated hemolytic anemia and platelet activation can lead to kidney failure and changes in the level of consciousness. Treatment of TTP was revolutionized in the 1980s with the application of plasmapheresis. According to the Ferlin-Tsai hypothesis, this treatment works by removing antibodies against the von Willebrand factor-cleaving protease ADAMTS13. The plasmapheresis procedure also adds active ADAMTS13 protease proteins to the patient, restoring a normal level of von Willebrand factor multimers. Patients with persistent antibodies against ADAMTS13 do not always manifest TTP, and these antibodies alone are not sufficient to explain how plasmapheresis treats TTP. Immune thrombocytopenic purpura. Many cases of immune thrombocytopenic purpura, ITP, also known as idiopathic thrombocytopenic purpura, can be left untreated, and spontaneous remission is not uncommon. However, counts under 50,000 are usually monitored with regular blood tests, and those with counts under 10,000 are usually treated, as the risk of serious spontaneous bleeding is high with such low platelet counts. Any patient experiencing severe bleeding symptoms is also usually treated. Thrombopoietin analogs have been tested extensively for the treatment of ITP. These agents had previously shown promise, but had been found to stimulate antibodies against endogenous thrombopoietin or lead to thrombosis. Romoplastin was found to be safe and effective for the treatment of ITP in refractory patients, especially those who relapsed following splenectomy. Heparin-Induced Thrombocytopenia. Discontinuation of heparin is critical in a case of heparin-induced thrombocytopenia, HIT. Beyond that, however, clinicians generally treat to avoid thrombosis. Treatment may include a direct thrombin inhibitor, such as lepirudine or argatroban. Other blood thinners sometimes used in this setting include bivalirudin and fondaparinux. Platelet transfusions are not routinely used to treat HIT because thrombosis, not bleeding, is the primary problem. Warfarin is not recommended until platelets have normalized. Congenital megakaryocytic thrombocytopenia. Bone marrow, stem cell transplants are the only known cures for this genetic disease. Frequent platelet transfusions are required to keep the patient from bleeding to death before the transplant can be performed, although this is not always the case. Human-induced pluripotent stem cell-derived platelets. Human-induced pluripotent stem cell-derived platelets is a technology currently being researched by the private sector, in association with the Biomedical Advanced Research and Development Authority and the U.S. Department of Health and Human Services, that would create platelets outside the human body.
Thank you for listening Dr. Izzy's medical podcast series. If you want to support this project, please subscribe the channel and like this video. Thank you.